Greetings everyone. A very warm welcome on behalf of Sightsavers to this webinar, Disability, Inclusive Sexual and Reproductive Health and Rights. I'm now going to hand over to Lisa Morris to officially start the webinar. Lisa, over to you.
Thank you, Roz. Welcome. It's my pleasure to welcome you all here today, our panelists, as well as our audience, everyone who's joining. I can see we already have more than 200 people joining. My name is Lisa Morris and I'm the moderator of this panel. I'm the learning advisor in the UK aid-funded consortium Inclusive Futures, and I sit in Sightsavers UK. Now, before we go into any detail, in terms of the topic that we have for you today, I would like to start by getting to know you all. We've had around 900 registrations for this panel. And we know that there's a huge amount of interest and expertise, not just on the panel, but also in our audience. I can already see we have some disability rights champions joining in the chat. We've collected questions beforehand as part of the Zoom registration, and we will aim to answer some of those at the end of the session. But to begin, we have two questions for you via Menti. So Russell, are you able to pull up the Menti slide if it's not there already? And also to drop the link into the chat. So please visit menti.com in your browser or on your phone and insert the code 64447054. That's 64447054. Now, if you're unable to access Menti, you can also post your response into the chat. And the response is an answer to the question, what is your knowledge of disability inclusion? So we have four options. I know nothing. That's totally, everyone is welcome. I know nothing. I know a little bit. I know quite a lot, or I'm an expert. So I can see the weighting is moving as the responses are coming in. And we have a range of knowledge and experience today, mainly in the I know a little bit or I know quite a lot area. So that's fantastic. We know that we're among peers here, and we really look forward to your contributions in the chat on this topic as well. And Russell, I wonder if we can move to the second question. While we're still gathering responses, if you've responded to the first question, you can use the same link. So that's menti.com 64447054, or you can again respond in the chat. I can see people responding. I'm an expert. I know quite a lot. Someone is asking for the code again. The code is 64447054. Thank you, Roz, for repeating that in the chat. So the second question is, what is your knowledge of sexual and reproductive health and rights? And the acronym we use is SRHR today. So we're bridging these two areas in terms of disability inclusion and SRHR. So we wanted to know, who's in the audience who knows something about either of these. And we seem to have more potential experts in terms of SRHR today, which is great. I can see 35 people know quite a lot. We've got a few experts in the room, 10, and it's building, so that's great. We really look forward to your contributions, as well as one very modest person who knows nothing. Appreciate your honesty, as well as those who know a little. I'd put myself in the between I know nothing and I know a little category. So definitely here as a moderator and not as a technical expert today. Thank you for those responses. It's really great to know who we have in the room. Again, encouraging your input throughout, and we'll aim to answer questions that you've already pre-submitted, as well as any others that we have time to answer at the end of the session. Thank you. Russell, maybe we take that slide down. Thank you. Now, I'll give us a brief background to the panel and the topic that we're talking about today before going to introduce the panelists. Now, the evidence and the approaches and the stories that our panel will talk through today are grounded in the experience in the Inclusive Futures programme. So the goal of Inclusive Futures is to develop innovative solutions to increase disability inclusion in mainstream development and humanitarian programs. So that includes education, includes livelihoods, but importantly today, it also includes health. And as well as delivering results directly for people with disabilities, we also aim to share learning, research and evidence about what works, about what doesn't work and why. And that includes in the area of disability inclusive SRHR. And I already saw some of those questions coming in before about, what can you share? What best practice is out there? We're not necessarily sharing best practice today, but we're certainly sharing practical examples from the program. And to set the scene, I can also emphasize here that sexual and reproductive health and rights is, of course, a human right, and that we use the term SRHR widely to encompass contraception services, comprehensive sexuality education, prevention of sexually transmitted diseases, antenatal, prenatal, childbirth care, as well as much more. And of course, if we're taking a rights-based approach, the Convention on the Rights of Persons with Disabilities, the CRPD, sets out explicitly that persons with disabilities retain their fertility on an equal basis as others. The CRPD also sets out that people with disabilities should be provided with the same quality of free or affordable healthcare, including in the area of sexual and reproductive health, as everybody else. It also sets out that people with disabilities have the right to decide freely and responsibly on the number and spacing of their children, and have access to age-appropriate information and education around their reproductive health. And strategically, we know the Sustainable Development Goal number 3 commits to universal health coverage. So that's to achieve good health and well-being for all. So to deliver on these commitments, we know that sexual and reproductive health and rights need to be inclusive. And yet we know that there is a long way to go, which is why we're here today. So on the panel today, we have 5 excellent speakers that it's my pleasure to introduce, who are all coming from the Inclusive Futures Consortium. Thank you. Now, we first have Rebecca Martin, who is a senior technical specialist in our consortium partner, Social Development Direct. And Rebecca will talk through her experience about SRH and disability. Welcome, Rebecca. We also have Lois Alter, who is the CEO and founder of the Network of Disabled Women Nigeria, who will share with us her experience collaborating on an SRH project in Nigeria. We have Anu Njama, Head of Research and Evidence in BBC Media Action. And Anu will be talking through communication designed to engage people with disabilities with SRH information. We have Mahendra Bikram Saha, Project Coordinator of Health System Strengthening Programme with Humanity and Inclusion Nepal, who will talk through a recently completed disability inclusive SRH project in Nepal. And we also have my close colleague, Dr. Joy Shuebu, Director of Programme Operations Nigeria, as part of Sightsavers. And Joy, who is part of Sightsavers, leads an innovative inclusive family planning project in northern Nigeria. And to close the panel today, we'll also be welcoming a guest speaker from our generous donor, the UK's Foreign and Commonwealth Development Office, Daryl Lloyd. Daryl Lloyd is the statistics advisor and the lead for FCDO's flagship disability-focused programme. So that's our run through of what you can expect over the next hour and a half. And really, without further ado, I'd like to hand over to our first speaker. So welcome, Rebecca. And Rebecca, really to start the conversation with you, the first challenge we often come up against with disability inclusion SRH is that there are gaps in evidence and in data. So we'd love to hear in your research what you have uncovered. Thank you, Rebecca.
Thank you, Lisa. At the Disability Inclusion Help Desk, we've produced a number of reports on disability inclusion and SRHR, including an evidence review on family planning for women and girls with disabilities in low and middle income countries, and an evidence digest on disability inclusive SRHR programming. We found that the evidence base on factors affecting access to and uptake of SRHR for people with disabilities in low and middle income countries has grown rapidly over the last decade. We found that this evidence tends to focus on the challenges and barriers faced by women and girls in accessing SRHR, and that there's more evidence on the challenges faced by certain groups, including women with hearing impairments and that there were gaps in evidence for other groups, particularly people with psychosocial disabilities and mental health conditions. In our research, we've also looked at the evidence base on good practice on increasing full, free and informed contraceptive choice for women and girls with disabilities. We found a lot more gaps there. Although there are organisations and projects working on this issue, interventions have typically not been well evaluated, or learning hasn't been documented and shared. Though this has improved over the last couple of years, notably through programmes such as WISH and the Inclusive Futures projects that my colleagues on this panel will speak about later.
Fantastic, thank you, Rebecca. And what are the factors that you find which affect access to and uptake of SRHR for people with disabilities? What affects access to and uptake?
Thank you. We found a range of factors which we've grouped in 4 main categories that you should be able to see on the slide coming up. Firstly, we have individual factors, which includes intersecting and compounding forms of discrimination, with barriers differing depending on the type and severity of impairment, and also on other factors such as a person's age, gender identity, sexual orientation, caste, race, or migrant and refugee status. For example, here we found that adolescent girls with disabilities often face particularly severe barriers. Secondly, we have environmental factors, which might be the first area that most people think of when they're considering barriers for people with disabilities, as this includes physical barriers to access at health centres and clinics, such as a lack of ramps, adjustable beds, and sanitation facilities that are wheelchair and disability friendly. This is compounded by long journeys to health centres and long queues for services once people get to them. We also found the accessibility of family planning messaging was an important barrier, and this might include a lack of captioning or sign language interpretation, or not having information available in easy to read formats. The third category, we found attitudinal factors. A common barrier raised here is the perception that persons with disabilities are asexual, which can lead to medical staff or caregivers withholding information on the assumption that people with disabilities won't need it. Another commonly raised barrier is stigma, negative attitudes, and discrimination from health workers. One study in Uganda found that negative and disrespectful provider attitudes at health centres was the most influential factor deterring refugees with disabilities from accessing services. And given the history and ongoing practice in some cases of forced sterilisation of women and girls with disabilities, it's particularly important to address these negative attitudes and discrimination so we can ensure the full, uncoerced and informed consent. Several studies have also highlighted how girls and young women with disabilities are infantilised and denied opportunities to make decisions about their own bodies and sexuality. Gender-based violence, and particularly intimate partner violence, can also limit access to and uptake of family planning methods. And then finally, we have institutional factors, which covers the need for national policies on reproductive rights of persons with disabilities. Despite advances made in ratifying the UN Convention on the Rights of Persons with Disabilities, which you spoke about, Lisa, many countries still lack legal guarantees and national policies for people with disabilities to have equal rights to health and non-discrimination. For example, a 2021 study found that in 23 Commonwealth countries, consensual sexual activity with people with disabilities is criminalised. And in 25 countries, sexual assault laws use derogatory language to refer to people with disabilities. Other institutional factors we found include a lack of disaggregated data to inform policy and programming, a lack of technical expertise around family planning programming from a disability perspective, and high costs to persons with disabilities of accessing these services. We found that all of these barriers can differ in severity depending on the type and severity of the impairment. So it's important to note that people with disabilities are not a homogenous group and to tailor these services and information provided. We found a study in Ethiopia that shows this really well. Discussion group sessions with people with a range of impairments revealed different types of barriers depending on impairment types. So for example, people with hearing impairments faced communication barriers, including a lack of availability of sign language interpreters, and many had negative attitudes towards family planning, partially caused by rumours and misconceptions around different methods. People with visual impairments face barriers caused by poor health facility design and infrastructure and poor conditions of the roads that led to the facilities, whilst people with intellectual disabilities face mistreatment from some healthcare workers and other staff. And then finally, we found evidence that these barriers were exacerbated by COVID-19 with lasting effects.
Thank you, Rebecca. Perhaps going back to the evidence gaps, what information did you find on good practice on increasing full, free and informed contraceptive choice for women and girls with disabilities, or SRHR choice overall? So what was the good practice that you found?
Thanks, Lisa. We did find a lot less evidence in this area, though it is improving. So there was a 2020 systematic review of interventions to promote SRHR persons with disabilities in low and middle income countries, which found nearly 400 studies documenting the SRHR needs and barriers for people with disabilities, but only 18 studies of interventions themselves. Despite this, there's emerging evidence of best practice, and some of this other colleagues on the panel will get into more. Firstly, the inclusion of women and girls with disabilities in the development of family planning policies and programming, in line with the disability rights principle of nothing about us without us. Evidence also shows the importance of peer education to improve the awareness of people with disabilities on family planning methods and services, including ensuring that key awareness raising and educational messages on family planning are tailored to the needs of people with disabilities. It's also really important to address attitudinal barriers with caregivers, communities and health workers, engaging family members on family planning interventions to get the buy-in from caregivers and create an enabling environment to improve access and uptake. Other examples of best practice include having satellite services and sexuality education for people with disabilities, collecting data to improve planning of services and policy, and ensuring that family planning services are accessible to people with disabilities.
Great, thank you. And perhaps one last question before we hand over. Did you identify any areas for further research?
We did, yes. We found a lack of systematic examination of how interventions can best address intersecting inequalities, such as disability, gender identity and sexual orientation, race and ethnicity, and other areas. We also found a lack of data on barriers and good practice for people with psychosocial disabilities, and a lack of good practice in increasing access to family planning for women and girls with disabilities in humanitarian contexts. Now, as Lisa mentioned at the beginning of our webinar, we know we have a lot of expertise with us in the virtual room today. So we'd like to invite some feedback from you through Menti. If we can bring the question up. So our question to you is, what barriers have you encountered, either professionally or personally, for persons with disabilities to access sexual and reproductive rights, health and rights? If you can keep your answers shorter, they'll show up a little bit better on the Menti, but I'll give you time to respond and look forward to seeing those answers coming back in as I pass over to you, Lisa.
Thank you so much, Rebecca. What a great way to kick off with some really fantastic evidence that you've been able to share from Social Development Direct, which I didn't say before, but also runs Disability Inclusion Help Desk, which is a fantastic resource that I encourage everybody to check out. Now, as those results come in, and again, you can reply directly via menti.com. It's a different code this time. The code has been copied into the chat, but also you're welcome to respond in the chat if that is more available. And I can see some fantastic responses coming in. Ruth Onyango says communication barriers and physical accessibility in the chat, as well as some coming up on the screen: abuse by health workers, organizations are not interested, people with disabilities considered asexual. So really, really important examples of barriers that we're all aware of in terms of the work that we're doing. And we'll make sure to share copies of the Menti, because I think it highlights some really important awareness, as well as copies of the presentation afterwards. I know that there's been requests for that in the chat, and we'll be sharing the recording as well. So just to let you know, you'll have those resources afterwards. Now it's my pleasure to hand over to our second speaker, Anu Njama, from BBC Media Action. Now, BBC Media Action have designed communication materials on SRH to reach people with disabilities in Nigeria. Now, Anu, can you please tell us more about this approach? Over to you.
Thank you, Lisa, and good morning or afternoon, everyone. So yeah, we conducted research similar to what Rebecca has talked about in terms of the research they conducted. We conducted some qualitative research as well within a couple of states in Nigeria. And from this research, we identified indeed pretty similar barriers and, issues around access to family planning and modern contraceptives for people with disabilities, similar to what Rebecca has described. So this research helped us to identify some key profiles of people with disability and family members or carers and people in their communities who are likely to access and use family planning and modern contraceptives or not. And this was important to help us shape programming. Now, the profiles are built around the primary audience types, as well as the key influencers, as the research identified. And as I mentioned, they represent people with disabilities, they represent their husbands or their wives, they represent healthcare workers, family members, and so on. We recognize, however, that these profiles are not representative of all the respondent categories that we did speak to on the study, but we focused mainly on those that are evidence-based behavioral archetypes that were uncovered. And from this research, we found profiles like Faiza, who is a young mother with hearing impairment, who wants to have more children. She's looking to space them and allow time for her body to rest. But she doesn't have the right information about family planning except from her friends and her family. But her husband is quite supportive of her decision to adopt family planning. We have someone like Abu. Abu is a man with visual impairment who is averse to family planning, and he believes that children are from God and measures should not be put in place to delay getting pregnant. Then we have Shadia, who is a person with physical impairment. She's unmarried. She's indifferent about family planning and modern contraceptives. She believes that these are for married people, and when she gets married, she will get all the information that she needs about this from her mother and her married siblings. Then we have Jamila. Jamila is a person with intellectual disability. She's very young, within the ages of 15 to 17. She's not aware of her reproductive health and needs, and her parents make the decisions for her. For someone like Jamila, she also, has to deal with the fact that her parents and family keep her in hiding, not wanting for people around to see her because they don't quite like the disability that she has. Now we have someone like Nazif as a member of our audience as well, who is a rural local government worker. His wife has a physical impairment. His biggest influencer is his mother, who helps to make decisions around family planning and related issues for the family. And Nazif doesn't believe in family planning, though family planning is accepted widely in his community. Then we have and caregivers of persons with disabilities, and our research shows that they influence the decisions for their family members who have disabilities. Their knowledge and acceptance of family planning and modern contraceptives vary, which means that whatever decisions they also make is subject to what they know and feel that their family member with disability needs. And then lastly, we have Rashidat, who is an experienced healthcare worker. She advocates for family planning for couples, but she does not support family planning for the unmarried because her religious beliefs do not align with that. She believes that people with disabilities should access family planning, but has little knowledge about their reasonable accommodation needs. So while she talks about the fact that family planning is accessible, everybody can access it, people with disabilities can come to the health facility and get it, she doesn't think about or know what the challenges could be, especially around access and reasonable accommodation needs. Now, these profiles, one thing we found around them is that except for the audience members like Jamila, who has an intellectual disability, and Faiza, who has a hearing impairment. We found that radio was one common source of information across all of these audiences, which in itself is informing the intervention approaches that we are adopting on this project. But aside radio, there are other forms of, or sources of information that these audiences have. We have, for someone like Jamila, who has an intellectual disability, she's more interested or gets information more from, visual interpretations of whatever information is being presented to her. For someone like Faiza, who has a hearing impairment, she would rather get information from videos that have subtitles. She'd rather get information from, family members, and any form of dialogue that comes with subtitles or interpretations in ways that she can understand. And all of this is informing the work that is being done at the moment. Now, these profiles are being used to shape the intervention strategy and to shape, media and communication content, as well as community level intervention approaches. For example, for the radio drama that's been produced on this project, characters have been built around these profiles. So we have males and female characters that have come off these profiles and have been designed to reflect the audience's needs based on what the formative research has shown. We've gone ahead to pre-test these characters that have been developed as a result of these profiles that this research produced. And we can already see audiences relating with these characters as people within their communities, as people around them, people that they know. We can already see audiences, relating with them in terms of their storylines and their journeys, and how this, should be carried forward in the drama and in the intervention. None of the characters so far were disliked by audiences because, of course, these were informed by research and have gone on to interpret what the research has said. And this has been taken on board into the radio drama and will be taken, these audience profiles would also help to shape social media content. It will help to shape community level interventions. And we look forward to how all of this eventually come together at the end of the project to help achieve the purpose and goal of this intervention. Thank you, Lisa.
Anu, fantastic. Thank you so much. Such rich examples of the work that BBC Media Action is doing. And I want to draw your attention, Anu, to a comment that we received from Rachel Mutonyi. I think it just came through to panelists, so not everybody saw it, but Rachel said, I've realized in all these stories of different individuals that they have different intersecting challenges. And I think the work that you just presented really, really highlights some of those complex intersecting challenges, as well as, including disability and affecting uptake and access to SRH. So thank you for that great example. Thank you, Rachel, for that comment. I'd like to move to our third panelist, Lois Order, and it's my pleasure to introduce Lois, who joined us in person in Thailand for the International Conference on Family Planning in November. And if anyone was there, you probably met her. She was definitely working the room and all of the booths and raising a lot of really important questions about disability and inclusion, and making some fantastic connections. Lois, it's great to see you this morning joining us from Nigeria. Now, you've been involved as CEO and founder of the Network of Disabled Women Nigeria in the planning and design of an inclusive SRH project involving Sightsavers, BBC Media Action, and of course other OPTs. Can you please share your experience about why it's important to meaningfully engage people with disabilities, and based on your experience, what is important to consider and what you raise? Welcome, and over to you.
Yeah, thank you very much, Lisa, for that brilliant question. And everyone in the room, thank you for listening. Yes, I am a strong advocate for the inclusion of women with disabilities in SRH activities and projects, because we realize we are the most excluded, the most poorest. We have been underrepresented, and we are sidelined for too long on SRH activities. And we need to be included. It is our right to access family planning, SRH, and other reproductive rights. Women and girls with disabilities have been trying their best to be included in Federal Ministry of Women Affairs and other women groups and associations. But when it comes to health, it is a difficult thing. Is it a woman with hearing impaired that cannot speak independently with a medical practitioner? They need sign language interpreters. Is it a woman in a wheelchair like me that goes to the hospital and the next thing I see is a staircase instead of a ramp? Is it a blind woman that cannot even see the road that leads to the hospital except she is assisted? And she needs to pay that assistant. And that's where poverty comes in. We cannot afford healthcare services and facilities like other women because of poverty, because of discrimination, marginalization, and stigmatization. I want to share a story of these issues I raised. I have a very close friend to my dear heart that was pregnant and she's a wheelchair user. She went for antenatal and the next thing was she fell off from her wheelchair on her way out after she was attended to. And instantly, she lost her pregnancy. This is a practical experience of what women and girls with disabilities face in their day-to-day lives. Another one was a deaf woman during COVID-19. She was heavily pregnant. She also went for antenatal. And the next thing that happened was, announcement was made that today they are not going to attend to other patients except patients with COVID-19. And she didn't hear the announcement. Other people that heard the announcement left the reception, but she kept sitting down, waiting to be attended to, until she got tired of sitting down and stood up to the receptionist and asked questions by writing. And the receptionist responded that announcement was made an hour ago that only patients with COVID-19 that will be attended to. So you could see practically that women and girls with disabilities are facing a lot of challenges when it comes to accessing healthcare facilities, particularly SRH services. We need to top up our game. We need to ensure inclusivity in everything we are doing on SRH services and facilities. Thank you very much for listening.
Lois, thank you so much. I'd like to draw your attention to a couple of comments echoing what you're saying. One from Trufosa Frida Mona, and my apologies if I mispronounce anyone's name. Trufosa says, direct involvement of people with disabilities is a sure way to change the narrative. I have seen this work. Being a woman with a disability myself, going to health facilities to pay support, supervisions has brought some progressive implementation of inclusive health services. If this is made the norm, then there is light at the end of the tunnel. And from Ranikon Dodozanova, Lois, you are great. You read my brain. There's a lot of such cases in my country. So a big thank you for sharing your experience as part of the Inclusive Futures program, as well as your wider experience. Great, thank you so much. Now, before we go to, we move to Nepal with our speaker Mahendra Bikram Saha from Humanity and Inclusion Nepal. I'd like to take just under 2 minutes to set the context. This is a recently completed Inclusive Futures SRH program in Nepal, and I believe we have a short video which we can queue up. Now, the captions on this video are quite small, so our live captioner will continue to caption throughout this video, and using the live captioner, you can change the size of the font. So you can choose to increase the font size for ease of reading. So I encourage anyone who is not able to access the smaller captions to choose the live transcript now and to change the font size. Russell, are you able to queue up the video? The audio is in Nepali, so it is a text-based reading unless you understand Nepali. Thanks.
प्रजनन मात्रै भन्नाले बच्चा उत्पादन गर्ने प्रक्रियालाई प्रजनन भन्छ।
ओके, ल ठिक छ। तपाईले भन्नुस् त यो पुरुष प्रजनन अङ्गको कुनै एउटा नाम भन्नुस् त। लिङ्ग। लिङ्ग। एउटा महिला प्रजनन अङ्गको नाम भन्नुस् त एउटा मात्रै। तपाईले भन्नुस् त। योनि। योनि। ल ठिक छ। अनि ल है उहाँले भन्नु होला किशोरी अथवा
यो शिखर एला क्लब हो। आज यहाँ यौन तथा प्रजनन स्वास्थ्यको विषयमा छलफल चलिरहेको छ। यी किशोर किशोरीहरू हप्ताको एक दिन यसरी नै भेला हुन्छन् र यस्तै जीवनोपयोगी विषयवस्तुमा छलफल गर्छन्।
प्रजनन भन्नाले अब सन्तानहरू उत्पादन गर्नलाई नै प्रजनन भनिन्छ।
खास गरिकन हामीले प्रजनन भन्नाले चाहिँ यौन कार्यमा संलग्न हुने जुन प्रक्रिया अथवा त्यसबाट चाहिँ सन्तान उत्पादन गर्ने प्रक्रिया नै हामीले खास गरी प्रजनन भन्छौँ।
सरले सिकाउनु भयो यसमा लजाउनु हुँदैन, यो हाम्रो स्वास्थ्यको लागि राम्रो होस्। हामीले डक्टरसँग गए पनि हामीले बोल्नु सिक्नुपर्छ। जस्तो कि हामी पहिला मम्मीसँग जान्थ्यौँ कि यस्तो भयो भनेर मम्मीसँग जाने, तर अब आफै पनि जान सक्ने हामीले यहाँबाट सिकेका छौँ।
हाम्रो यो प्रजनन स्वास्थ्यको विषयमा चाहिँ हामीले कुनै पनि कुरा नजानिसके पछाडि चाहिँ हामीलाई धेरै गाह्रो हुन्छ, धेरै अप्ठ्यारो हुन्छ। यो भनेको नितान्त हाम्रो स्वास्थ्यसँग सम्बन्धित कुरा हो। त्यसैले हामीले यो विषयमा चाहिँ एकदमै खुलेर बोल्नुपर्छ भन्ने कुरा चाहिँ मैले उहाँहरूलाई पनि सिकाएँ र आफूले पनि सिक्दै गएँ। अहिले चाहिँ पहिला सुरुमा उहाँहरूले पनि एकदमै लजाउनुहुन्थ्यो है, हाँस्नुहुन्थ्यो, लजाउनुहुन्थ्यो है। म पनि हाँस्थेँ, तर आजभोलि चाहिँ एकदमै त्यो सबै निमिट्याउनु भएर गएको छ। हामीमा त्यस्तो लाज नै छैन र यो यौन प्रजनन स्वास्थ्यको विषयमा एकदम हामीले खुलेर कुरा गर्छौँ आजभोलि।
Great, thank you. Well, we could go on with that video. It's a fantastic example of the context and the work that's been done in Nepal with adolescents with disabilities to start to increase access to information, to support improved healthcare services, and to deliver results directly for youth with disabilities. I want to acknowledge there's been a few requests for that video in the chat, as well as the transcript to that video. So we'll make sure that we circulate both as part of the follow-up email. But now I'd like to hand over to our Inclusive Futures Consortium partner, Mahendra Bikram Saha, who joins us from Nepal, from the very project where we've just seen the video. Now, welcome, Mahendra. You've been part of the Inclusive Futures program in Nepal, where there is a recently completed project, as we just saw, focusing on access and uptake, as well as information around SRH for adolescents with disabilities. And based on that completed project, we'd love to hear about the approach as well as any takeaways, what seemed to work well based on your experience. Welcome, and over to you.
Thank you, Lisa. My short talk will be focused on little bit background, which is already covered by Lisa, and I will share about some tested approaches and key takeaway message. And overall goal of this initiative, actually the Inclusive Future initiative in Nepal, was enhance well-being and inclusion of young people with disabilities by enhancing access and uptake of quality and inclusive SRHR. And we are focusing young people, that means 13 to, let's say, 24 years people. We did some well-defined strategically designed activities. We started from baseline study. With that baseline, we map out the issues prevalent in community. For example, only 7.4% of young people were practicing or were attending sexual reproductive health services delivered by government and other government partner service providers. And and one thing interesting, we got that girls have little bit more knowledge regarding sexual reproductive health in comparison to boys. And after this baseline, we intervene various activities, and you just saw that video, which was after school club, where both youth with disability and youth with without disability were engaged in some forum, and there were created a nice safe space to interact their day-to-day curiosity and some issue faced by them. They can't express their share their issues with their parent and school, but in peer group it is easy for them to share and to resolve some issues related to sex, sexuality, and some information and services. And also this initiative has carried out capacity building activities for health workers, school nurses, female community volunteers, so that their access and uptake of information and service can be made available. And another thing, partnership with organization of person with disabilities and governing authorities was crucial, because of organization of person with disability, as per the policy provision, they have big role to make evidence-based advocacy, and resource is with governing authorities. If they work together, it will be easy to operate the inclusive sexual reproductive health program. And beside this, with the facilitation of organization of people with disabilities, local municipalities, local governing authority realize the need of young people, and they deploy vulnerable focal point. And another important intervention was just carried out formulation of some joint group and carried out accessibility audit, and later on with support of project and government support, 30 health facilities has improved their accessibility arrangement by adapting, modifying, and some developing signage, etc., and making parallel bar ramps, etc. And these things are, I like to share some photos to a little bit elaborate what I said. For example, here, government nurse is giving counseling to clarify some issues for young person, young man with disability. And a vulnerable focal point deployed by municipality went in community to interact about the adolescents, boys, girls issue with their mothers. And this already covered in last video. And also some assistive mobility devices and some equipment were transferred to local health facilities so that the quality sexual reproductive health can be delivered. Here we invited some academician actually who are person with disability, and they played two roles. They deliver good message as well as they were the model or who can influence the all concerned actor related to inclusive sexual reproductive health. This is that was the accessibility I already covered, and this is the some IEC behavioral change communication material was developed, and it was given, and they got easy to discuss among person with young person with disability and without disability. And sometime vulnerable focal point went to resolve some operational issues with government person. And they established some help desks which provided not only a service for related to health sector thing, but also they provided the social protection provision of government, like developing, issuing disability identity card and providing the government a provision to who are entitled to get. Yeah. And now I like to share some, in short, some takeaway messages. Number one is we have to intervene being based upon right-based approach rather than welfare thing or social service thing, because as already one of the panelists already shared that health is health. And sexual reproductive health is fundamental right of a person with disability. All concerned people have to program on right-based approach. And another thing, especially women, socioeconomically deprived women and socioeconomically deprived women with disabilities face so many difficulties, and their intersectional issues are related to society, related to family, related to different area. They have to be resolved well. Just superficial attention may not be effective. So we have to go a little bit down, and their supporting mechanism has to support it. And also right has to be sensitized well. Other thing are meaningful engagement of people with disability, maybe promoting OPD network of organization of person with disabilities and self-help group. We have to carry out evidence-based advocacies. Another thing, data is very important in developing countries. For example, we may not have the entire trustable, let's say, quite trustworthy disability prevalence rate in any country. So if we generate exact data and diverse data, it will help local people, especially decision maker, to plan evidence-based planning, and later on they can check their milestone. Otherwise, it will be not effective. And I think last but never the least, we have from family, from group, from family, from community, and from government and service provided. I think stigma and discrimination has been tackled at personal level, at let's say organization level, and at the role of the government. If government has developed some Disability Right Promotion Act, then only act will be not sufficient. And to tackle stigma and discrimination, some effective programming has to be carried out. Yeah. This is my last slide. Now it is I transfer microphone to Lisa.
Mahendra, thank you so much.
Yeah.
So many key takeaways that you managed to embed there. And it's so fantastic that what you're speaking about is actually based on the practical experience from the project. This is not theoretical. This is directly based on experience working with people with disabilities and their representative organizations in Nepal. Thank you. Mahendra, I also want to draw your attention to some questions coming in the Q&A box. And I'd like to draw everyone's attention to them because I've just realized that anybody can answer them. And we have 330 people on this panel today in terms of participants. And we know we have a lot of expertise in the room. So I really encourage you to answer each other's questions, to share your resources and your links as well. If you are replying, please reply all or reply everyone. And Mahendra, there is a question from Pashal. Could you please explain more about providing vulnerable focal points to support service delivery? So that might be one that you want to take on in a text-based response in the chat.
Yeah, as per Disability Right Promotion Act, there is a good provision of Disability Coordination Committee, but most of their effort are focused only in delivery of issuing of disability card and distributing allowances. But that is not the ultimate, let's say, support. And to let's say to deliver quality service, to enhance uptake of service, I think some resources are to be allocated. And as per local, now 7-step planning process is there, but sometimes it is not done well. In this situation, if person with disabilities and their organization talk with local decision maker, they can make provision of resource. Like this vulnerable focal point was the example. A local person deploy some let's say paramedical and youth in local municipality. They did do two things. One, they facilitate to issue of disability identity card, and also they link different service provider, maybe let's say health, education, and some livelihood service provider. And this focal point facilitate young people with disability. And in big picture, and some issue are resolved. Yeah.
Mahendra, thank you for explaining, Pascal. I hope that Pashal, I hope that responds. So a really practical example of a focal point in between municipality, in between health services and youth with disabilities. Thank you, Mahendra. Now, I'd like to hand over to our final speaker. Before we have time for so many of the rich questions coming in, handing over to my colleague, Dr. Joy Shuebu, who is the Director of Program Operations in Nigeria with Sightsavers, who, as part of Sightsavers, has been leading an innovative family planning project in Nigeria. Now, based on all of the speakers that you've heard and your fantastic experience, Joy, I'd really love to hear what you have to add to this conversation today. Thank you.
All right, thank you very much, Lisa, and good morning, good afternoon, and probably evening for people who are joining us today. Thank you for finding the time to come. And if you've listened closely to the panelists, you know that most people would like to have an inclusive sexual reproductive health program. And from our experience, we realized that most people who are not able to do that, it's not because they don't have the intention, they don't know how to. And today we've tried to share a lot of practical examples on how to go about that. And I want to just hinge that on one of the innovative programs that we're currently implementing in Nigeria, just to walk you through some of the things that we are doing and have done. So first and foremost, the most important thing is having the appropriate data, because you want to start out from a place of evidence to support what the intervention is, and to also measure the progress and the impact of the intervention at the end. So we did a lot of surveys, we did a lot of desk reviews to find out, what the issues are, so that it will best position us on how to tackle the barriers that persons with disability face in terms of accessing sexual reproductive health services. And following from that, we also looked at who were important to bring into the room. And one of the most critical stakeholders that you want to have in the room if you're looking to develop an inclusive sexual reproductive health program are organizations of persons with disability. And Lois represents that organization alongside with JONAPID and some of our OPD colleagues in Nigeria, because you want to ensure that you're empowering persons with disability and putting them in the place where their voices can be heard. And that is absolutely important. And in the course of our project implementation, we have made sure that that is so. So at the point where BBC Media Action were trying to formulate the research questions that would help them go to the community and find out the barriers that exist, persons with disability were there to provide input. When the results of the formative research were ready, persons with disability and organizations of persons with disability were there to input in the process. And currently we're designing social behavior change communication materials that will help us address some of these barriers. And I can assure you that organizations of persons with disability are also involved through this process and providing input. Our family planning program in Nigeria that seeks to showcase that sexual reproductive health services can be inclusive of persons with disability focuses strongly on a social behavior change communication approach. And with this, we seek to first and foremost influence behavior among persons with disability themselves. We've realized that their families are also very key in making decisions on their behalf. So we're also seeking to influence behavior and developing messages that can help improve the knowledge that these people have, so that they can also make the right decisions on behalf of persons with disability where that need arises. We're also focusing on healthcare providers because we realize that the attitude of healthcare providers is essential if you want to provide inclusive health services. So we're going to be doing trainings for healthcare providers and helping them understand how best to relate with persons with disability. And just going back to what Lois mentioned, we're also conducting accessibility audits, physical audits of the facilities where persons with disability are expected to go and access these services. And we're doing that alongside with the government partners, and we're seeing very positive results because now they are able to include accessibility features in new buildings, and they are also willing to make some modifications in existing health facilities so that persons with disability are welcome. There are other things also that Sightsavers is doing, including developing basic sign language manuals that would help health workers to attend to persons with disability, especially those with hearing impairments. And collectively, we're putting the government in the center stage and advocating strongly that persons with disability are made members of health committees and working groups as regards to the availability and access to reproductive health care services. And so it is possible to have an inclusive sexual reproductive health care service delivery. But you need to be innovative, you need to understand the context, you need to find the right people in the room. It's also important to make sure that these approaches are evidence-based so that they can be replicable across board. So like Lisa mentioned at the beginning of this panel, we cannot talk about universal health coverage without talking about sexual reproductive health services. And we certainly cannot talk about sexual reproductive health services without talking about inclusive sexual reproductive health services. So we're moving away from the charity model, and like Lois has mentioned, we're advocating the right-based approach. Persons with disability have rights, sexual reproductive health rights. And so if we're looking to make sure that we're fulfilling the SDGs, especially in terms of health, we need to take seriously, including persons with disability, and making sure that their voices are heard. I'm hoping that we have given you practical suggestions about how to go about implementing an inclusive social sexual reproductive health program. But of course, like Lisa has mentioned, we're available to share learning. We're also available to also learn from other people who are doing the same thing in other fields. But I think in general, it's a collective effort. We need the efforts of the donors. We need the efforts of the research groups. We need the efforts of the media. We also need government policies to ensure that together we can make sure that we have inclusive sexual reproductive health care services. I think I'll stop here, Lisa, so that we can attend to some of the questions that have coming and some comments also. Thank you for listening.
Dr. Joy, thank you so much for that really, really great perspective and summary. And Anessa Hamilton-Legend in the chat said, awesome work being done there in Nigeria. Hamida in the question and answer requested if we could share the SBC social and behavioral change materials produced for people with disabilities. Now, I know that this is an ongoing project in Nigeria. We have about 2 years left, and the formative research has just been done. The communication materials are just starting to come out. So I think there's a huge potential for more evidence and learning to be shared over the next 2 years, which is a great opportunity, and it will be shared on the Inclusive Futures website. Thank you so much, Dr. Joy. Now we have about 20 minutes left. I'd like to leave time for our guest speaker to close, but I think that probably gives us about 10 minutes to respond to the wealth of questions that have come in as part of the registration and as part of the questions in the chat to begin with. Now perhaps we can get all panelists up on our screen. Dr. Joy already began to respond to quite a few questions we received beforehand about best practice. So what's out there, you know, what best practice, what's the one thing that has worked? I hope we've presented a range of practices we've tried and some of the experience that has been captured so far, and also encouraging others in the chat to to share. Perhaps I can raise the question around intersectionality, which has come up quite a lot in pre-registration. Some really important questions that I think it's great if we attend to, and it's also come up throughout our presentations and in the chat today. So for example, how inclusive are we talking? What insights do we have on trans health rights and the crisis of access to competent care? Or please address intersecting vulnerabilities, e.g. sexual orientation and their impact on SRHR. As well as some of the questions coming in today around intersectionality, for example, reaching people in rural areas or reaching people in different age groups. Now, this perhaps we can look at what evidence research or data we have or gaps that we're aware of. And perhaps, Rebecca, is it okay if I hand over to you based on the research that you've done with the Disability Inclusion Help Desk in SD Direct to kick us off on that question?
Yes, thank you, Lisa. It's a really important question because we found a lot of evidence on the importance of taking an inclusive and intersectional approach. Considering gender dynamics is really important. We found that women, particularly young women and girls, can face a range of different barriers, some of which we've already spoken about, including being infantilized or not being recognised as an authority on their own needs. We also found some evidence on the barriers for men with disabilities, and some of this has come up in comments in the chat as well. So, for instance, we found evidence of men with disabilities being excluded from SRHR services and programmes in Uganda, as family planning was seen to be a female affair, which restricts the access of men, but also puts a burden of responsibility onto women and continues unhelpful stereotypes there. And then the questions about LGBT inclusion. The Disability Inclusion Help Desk recently published an evidence digest that focused on the available evidence of LGBTIQ plus people with disabilities, and we found limited evidence relating to this group in low and middle income countries in general, not just in relation to SRHR, but in relation to SRHR, we found that attitudinal barriers can be a particular issue. For example, LGBTIQ plus people with disabilities facing additional stigma and discrimination at healthcare facilities. And then we also found evidence of a lack of consideration of LGBTIQ plus concerns in comprehensive sexuality education for people with disabilities.
Thank you so much. Is there anything else our other panelists would like to add? And also acknowledging our other panelist, Lois, who is still here, but I don't think the video is connecting, so they're not showing up. Is there anything else any other panelists would like to add? Or we can move on to the next question. Thank you, Rebecca. Okay, fantastic. Now, there's also been questions being asked in the chat around and in the registration around standards and laws. How do the Sustainable Development Goals and the CRPD address the sexual rights of people with disabilities? And is there a country that has adopted a separate law or policy? Are there special standards? I think we've hopefully touched on some of the details in the CRPD specifically, and also there's been reference to specific disability inclusion laws in the different countries. Hopefully that's sufficient, but I wonder if any other panelists would also like to contribute further to provide clarity around the rights-based approach and the legal commitment. And I can see Lois joining as well. Fantastic.
Shall I just like to share that Nepal ratified UN CRPD in 2010, and with long gap, Nepal developed Disability Right Promotion Act in 2018. As per this act, now at provincial and federal level, some inclusive health guideline is developed, and sexual reproductive health is also part and parcel of that guideline. And I am hopeful that in upcoming year, I think there will be good intervention by this development. Thank you.
Okay, thank you so much, Mahendra,
Yeah.
for responding. So in Nigeria, we have Nigerian Disability Act, and Article 17 to 20 talks about the right to access healthcare services, including SRH. So UNCRPD, Article 25, also talks about that. And it's good that we begin to strategize on the implementation, because that has been a big issue and a problem in many countries, especially in developing countries. Americans with Disability Act are doing well. And in the UK too, they are doing well. But we need to do well in other continents that their countries are still on the developing stage. Yeah.
Thank you so much, Lois and Mahendra. Great to have this awareness and these examples. Perhaps I can come back to you, Lois, with some questions that are coming up around, let me find them, around choice and informed consent. So how to make sure that autonomy, individual autonomy for each person, is really at the center of how SRH is provided. I wonder if you have any comments or examples or guidance around ensuring that there's always informed consent with the with each person. Over to you.
Yes. Assessing sexual reproductive health rights independently is a good thing, but in some countries, they don't. Just like Anu shared the research results that they have done, some of us in the North, especially men, they don't believe in women accessing sexual reproductive health services because they feel everything should be natural, and women need to get permission from their husbands. They don't have rights to their bodies, and so much on patriarchy, cultural norms, and other perspectives. So I think when it comes to rights, using the human rights model, we need to allow everyone to access whatever they want to access, whatever they want in their bodies. I'm an advocate of human rights, and I want to say with a loud voice that body autonomy is allowed. We need to access those services independently without any interference. Thank you.
Thank you, Lois. I don't know if any other panelists would like to come on, or if we move to the wealth of questions we have around data. Okay. So we also have quite a few questions coming in around data. I know, Mahendra, this was one of your key takeaways around the importance of supporting national governments to collect and disaggregate and analyze disability data, as well as the importance of using it for monitoring to make sure to understand who programs are reaching or not reaching. There's been a few questions around what are the best practices to ensure quality data is captured. There's a comment from Bernadette Crawford around perspectives on Washington Group questionnaires. So I know that all of our panelists, as part of the Inclusive Futures programme, collect disability disaggregated data in potentially different ways. So very open to hearing whoever would like to come in to start to share experiences around disability disaggregated data. particularly in the SRH setting. Mahendra, I wonder if you would like to kick us off. Thank you.
Basically, I think as per government policy instrument, maybe categories of person with disabilities may be more or less. For example, we were using 7 types of category, but recently from 2018, now we are using 10 types of person of disability. And universal accessibility, one thing, but specific accessibility is very important as per category of person with disabilities. So in general, I think aggregated data and disaggregated data both are important to make evidence-based planning, to allocate proper resource, and to monitor, track the milestone. So I think for even good governance, I think data is very important. For this, I think international agency and some expert organization may be useful to support local governing authorities, because they have good intention, but sometimes they lost themselves for making good collection of data. Thank you.
Thank you. Yeah, it shows the multiple people that need to be involved to ensure good collection of data. Thank you, Mahendra. Would anybody else like to come in on the point around disaggregation of data?
Yes, maybe briefly to say that the health system needs to be involved. So if we're going to make any changes and see that we're collecting inclusive data, it's important for programs to engage with the government and the systems of data collection, so that as the data collection tools are developed, that will bear that in mind. And of course, it will help us have an inclusive data society. But that is absolutely important. Thank you.
An inclusive data society. I like that phrase. Thank you, Dr. Joy. Well, perhaps with respect to time, we'll look at wrapping up the Q&A. And as we do so, I want to point our panelists and everyone's attention to some of the final sort of points from Amy Russell. How do we stop reinventing the wheel? There's so much good work and excellent resources. So we don't need to start from scratch. You know, where can we share what's already being done? And Amy Russell, I'm so glad that you raised this, as well as several other participants. You know, this call for continued evidence based on practical experience. We know that there's a lot out there in SRH, in disability inclusion. We're really keen to continue to bring these resources together. Everything that we've spoken about today, you can continue to follow updates in terms of what we're sharing via Inclusive Futures. So we'll make sure that that link is shared in the chat. And as part of the program, we have a commitment to continue to produce learning and research and evidence, as well as drawing on all of the great research and evidence that is already out there. Now, perhaps we can hand over to our guest speaker to begin to wrap up the panel today. Now, Daryl Lloyd is a statistician in FCDO, the Foreign and Commonwealth Development Office, who also leads the flagship disability inclusion program as part of FCDO. So it's my pleasure to hand over to Daryl as we begin to wrap up the session.
Many thanks, Lisa. And thank you very much for inviting me to say a few words at the end of today's session. As often happens at this time, I feel like a bit of a fraud, because we've heard from a panel of true experts on SRHR, and they've spoken about incredible programs designed to help people with disabilities to access the rights they deserve and are entitled to. And I definitely can't add anything of wisdom above and beyond what they've said. I have nothing like the expertise and knowledge they have, but I can say something, a little something about the approach the UK and the Foreign and Commonwealth and Development Office is taking on inclusive SRHR. First of all, we've been very fortunate to have inclusive futures involved in so many of FCDO's disability inclusive programs. And we've heard of 2 projects today, Lafire in Nigeria and Sal in Nepal, which have been making fantastic progress and helping us understand how we can make our health interventions much more inclusive across the whole of our work. But to make the most of the lessons coming from these programs and the things we've been talking about today, they need to be shared and implemented elsewhere, not just within those programs. It's relatively easy to include persons with disabilities in interventions if we focus purely on them. And in some ways, this is what we've done under our Disability Inclusive Development Programme. But when we have disability focused programs and policies, they'll only ever have a limited scope. They often consider persons with disabilities and persons without disabilities as almost 2 separate groups of people. But that doesn't reflect the society and the world we all live in. And populations are made up of persons with disabilities, persons without disabilities, women with disabilities, women without disabilities, Indigenous peoples with disabilities, and, well, I think you kind of get my point there. So when we published our new disability inclusion and rights strategy last year, we highlighted the importance of a twin track approach. And then, therefore, rather than asking, how do we design programs that specifically target persons with disabilities, we really should be asking, how do we make sure that the activities and programs we're undertaking are inclusive of the needs of the whole population, including those people who have disabilities? And this will help us take that step from small targeted interventions to approaches that have the capacity to reach many, many more people and cut across whole populations. Specifically on SRHR, we made 3 commitments in our strategy. The first one is to, I'd say, that point of mainstreaming and twin track mainstreaming. So we want to mainstream disability inclusion throughout our global health work, and that includes encouraging bilateral and multilateral partners to incorporate disability inclusion in their activities. Secondly, we just had a question on data, and that's really relevant because we want to help countries strengthen their capacity to collect and analyse health data, which is disaggregated by disability. And the Washington Group questions are a core part of that. And thirdly, we want to support the advocacy, inclusion and meaningful participation of persons with disabilities. And we want to and need to engage OPDs in our SRHR programming. This is the only way we can really hold true to the maxim of nothing about us without us. And the great thing is the activities we're doing there is we're about to release or finalise some internal guidance on how FCDO staff should consult with OPDs. And we did consult actually with OPDs and a number of people on this call who are here today on how to do that. So we're very grateful for that input. And we've heard lots of great examples today about how SRHR can be made inclusive. And I'm not going into any detail at all, but part of our funding to the partnership in maternal, newborn and child health includes explicit actions on how to apply disability lens. And we're pleased to see how much progress they're making in that. But we need challenging, and we need reminded about this too as donors. In times of funding shortages, it's very easy for donors to sacrifice inclusion as, quote, it costs too much. But equity is one of FCDO's 5 E's of value for money. It costs more to be inclusive, but that's a justified cost to ensure we do not leave people behind. So I just want to end on my kind of final point here is I encourage you all out there, whether you're OPDs, whether you're NGOs, whether you're activists in the area, don't let us off the hook. Don't let us use funding and costs as an excuse not to be inclusive. We need to be reminded that we need to be driven to carry on doing that. So I think I've taken all my time. So thank you very much. It's been a fantastic session, and I will hand you back over to Lisa.
Fantastic, Daryl. Thank you so much. We have that on recording now to not let FCDO off the hook. And great to hear that ongoing commitment around equity and leaving no one behind. I'm sure everyone on the panel and in the audience today deeply, deeply agrees with that commitment. So it really is my pleasure to wrap up here, to say a huge thank you to everyone who has stayed on till the end with a huge amount of participants. It's been so great to see how important this topic is to so many people. we really look forward to staying in touch with everyone. Please visit the Inclusive Futures website, where we continue to share information, not just around SRHR, but also our other disability inclusion programming in health, in education, in livelihoods, in negative stereotyping and discrimination. There is a newsletter link you can sign up to, and you can also find us, for example, on the all the channels that you might otherwise use. We will also be sending out an email to everyone who registered with the recording, as well as the resources that the panelists have generously shared in the chat. And we look forward to continuing this conversation and to sharing more of what we're learning, as well as hearing from you all over the next few years with Inclusive Futures. And we'll end here. Thank you so much.